Hello everyone, thank you for taking the time to join the session today. My name is Susanna Ikwen. I'm a Public Health Protection Officer for Luton Council, and today I'll be presenting a summary of the Influenza or Influenza-like Infections Pandemic Plan developed by the Bedfordshire Local Resilience Forum. So this plan outlines how we prepare for and respond to a respiratory pandemic, drawing on recent experiences and national guidance. In this section, I will outline the aim and objectives of the pandemic response plan for managing influenza and other influenza-like infections within the Bedfordshire Local Resilience Forum area. Main aims of the plan are to establish precautionary, appropriate, and flexible arrangements for managing a pandemic, particularly one caused by a respiratory virus, very similar to the COVID-19 pandemic experienced in 2020. So with the precautionary element, planning is based on current risk assessments and available information, ensuring that all strategies are informed and relevant. For the appropriate element, the plan is designed to be scalable, allowing for adjustments based on real-time intelligence during an outbreak, and flexible. It must adapt to local conditions in Bedfordshire, considering variations in population, density, and socio-economic factors. And then with the objectives of the plan, they are as follows: to detail the command, control and coordination arrangements necessary for managing respiratory pandemic level infections, including influenza and coronaviruses. Roles and responsibilities include outlining specific roles for various organisations during different phases of the national response. Particularly in public health, the focus is on minimising community disruption, prioritising health and social care services and provision, and also to identify and mitigate health inequalities, ensuring equitable access to healthcare for all patients and staff throughout the pandemic. Again, there is also the recovery objective as well, which is to restore and recover services inclusively, taking into account considerations of equality and health inequalities. So in conclusion, this plan is essential for ensuring a coordinated and effective response to future pandemics, prioritising community health and equity. This is just also a reminder that this plan is designed to complement national strategies and is linked to several supporting documents, which include the NHS England Operating Framework for Managing the Response to Pandemic Influenza 2024. There's also the BLRF Command and Control Plan, the BLRF Vulnerable People Plan, and the Excess Deaths Plan. So just bearing that in mind when looking through this plan for guidance, that there are also additional documents to look at as well. In this section, I will define what a pandemic is and discuss influenza-like infections, including their symptoms and impact on health. So the definition of a pandemic is defined as a widespread transmission of an infectious disease across multiple countries and continents. This typically occurs due to a novel pathogen such as a virus or bacteria to which the population has no pre-existing immunity. So some key characteristics of a pandemic include the ability to infect people and spread from person to person. A high proportion of those infected may become ill, and widespread transmission as most individuals lack the immunity to a new pathogen. So I'm just going to list some signs and symptoms of an influenza-like illness. So this typically refers to conditions that present symptoms similar to influenza, regardless of their laboratory confirmation. So this would include a fever above 38 degrees, respiratory symptoms such as a cough or a sore throat. Other symptoms may also include chills, fatigue, dry cough, decreased appetite, body aches, nausea and sneezing. Symptoms typically appear suddenly and are associated with a non-specific respiratory illness, often resolving on their own within a few days to weeks. So the impact on vulnerable populations is quite different. Respiratory infections can exacerbate existing health conditions, increasing the risk of severe illness and sometimes hospitalization. So complications from these infections may lead to serious health issues, including death sometimes. The NHS has identified identified several groups that are at high risk for serious illness, which include those over 65, pregnant women, residents of care homes, caregivers or main caregivers for older or disabled individuals, those living with someone who has a weakened immune system, or individuals with long-term health conditions such as COPD, heart conditions, chronic liver disease, diabetes, a weakened immune system due to conditions like HIV or AIDS, learning disabilities, or individuals with a body mass index of 40 or above. So in conclusion, influenza-like infections are respiratory illnesses that can be caused by various pathogens, not just influenza viruses. And a pandemic occurs when a new or highly transmissible infection spreads globally, leading to significant strain on healthcare symptoms and exacerbating health conditions. So in this slide, I will be talking about the command, control and communication that takes place during a pandemic. So the Health Economy Strategic Coordinating Group, also known as HESCG, leads the pandemic response across Bedfordshire, Luton and Milton Keynes. So it ensures an integrated strategic approach coordinating across NHS, local government and other essential services. Timely and accurate communication is crucial to public reassurance and effective response. The NHS has a structured framework with 4 incident response levels ranging from organisation level responses to national level coordination, ensuring a cohesive approach to managing the pandemic. Level 1, organisation level response. This is coordinated by individual organisations to manage their internal response to the pandemic. Level 2 is local level response. So this is managed by the ICB in collaboration with NHSC regional team to address local needs. Level 3, regional level response. So this is coordinated by the NHS regional team to oversee and support responses across multiple local areas. And level 4 is the national level response. So this again is led by NHSC national team in conjunction with the Department of Health and Social Care, focusing on a coordinated national strategy for pandemic management. So there are several coordinating groups that are listed in the pandemic plan to coordinate and support with the response to a pandemic. So as mentioned previously, there's the HESCG, which is chaired by the BLMK-ICB, and the role of this group is to ensure coordinated local health response to the pandemic plan. Some responsibilities include overseeing the multi-agency incident management, establishing policy frameworks for effective coordination with the TCGs and response cells, focusing on the preservations of life, supporting health services, maintaining essential infrastructure and facilitating recovery to restore normality post-incident. The Strategic Coordinating Group, also known as SCG, is led by the Department of Public Health, and this prioritises collective goals, establishes communication strategies, and manages media inquiries for cohesive response efforts. The other group involved in the coordinated response is the Health Economy Tactical Coordination Group, also known as the HETCG. This is also chaired by the BLMK-ICB, and their role consists of coordinating the NHS and public health response to ensure services continuity across all health organisations. Compositions of this group will include acute mental health, community health trusts, local authority health and social care, and other relevant entities. The HETCG reports to the HESCG. There are also detailed action cards of the roles and responsibilities for all departments involved in the response, found in Appendix 3 of the plan. These include agencies like the UKHSA, the BLMK-ICB, Local Authority and Bedfordshire Police and the Coroner's Office. In this next slide, I will be talking about equality and health inequalities when it comes to responding in a pandemic. So NHS England's commitment states that the NHS England is committed to reducing health inequalities as mandated by the National Health Service Act of 2006. Key objectives include eliminating discrimination and fostering positive relationships among diverse groups, and ensuring integrated services to effectively reduce healthcare disparities. During pandemic responses, it is crucial to safeguard staff, patients, and the public while considering health inequalities and guidance development for major incidents. So, some of the impacts of COVID-19 on health inequalities. The pandemic has reinforced existing health disparities affecting communities in varied ways. Vulnerable ethnic groups experience significantly higher mortality risks. Bangladeshi individuals face double the risk of death. Black African men have 3 times the risk compared to white British individuals, and other groups experience 10 to 15% higher mortality rates. Contributing factors to these include pre-existing health conditions and a lack of targeted support, which have exacerbated these disparities. Inclusion health groups such as the homeless, drug users, and migrants faced heightened risks during the pandemic. Another key thing to note with inequalities are the vulnerable population. So disabled individuals and clinically vulnerable groups experience distress due to negative narratives and concerns about treatment prioritization. So when planning for future responses, it is essential for command units to engage specific communities in planning efforts. Decisions that impact health inequality should be thoroughly documented and justified to ensure accountability. There are more resources available for further insight, which can be referred to, such as the Health Profile for England 2021, the Build Back Fairer, the COVID-19 Marmot Review, and also the Community Engagement and COVID-19 Report for Bedford Borough and Central Bedfordshire. So in conclusion, addressing health inequalities is vital for effective healthcare delivery, especially during and after a pandemic. In this section, I will discuss the coordinated actions that are essential during the pandemic response phase, focusing on business continuity, public communications, and medical distribution. So with the BC plans, organisations across all sectors must have robust BC plans in place to address the impact of staff absenteeism during the pandemic. These plans should be flexible and scalable so that they can be adapted to various pandemic scenarios from mild to severe. They should also be detailed, so they outline how to maintain essential services and business operations for several weeks during peak pandemic activity, ensuring that business as usual is upheld as much as possible. For public communications, effective communication is critical for a successful pandemic response. So key points would include consistency and clarity. Messages should be clear and tailored to different audiences, available in multiple languages to ensure accessibility. Leadership, the Department of Health and Social Care will spearhead national health communications, working closely with the government partners and local representatives to foster public trust and support for health measures. Points of dispensing. The ICB will collaborate with the Directors of Public Health to establish points of dispensing for public medication distribution during the pandemic. So there will be 2 types of pods that will be set up, centralised pods and decentralised pods. So with centralised pods, you have multiple locations where they will be set up for the public to visit for vaccinations and medications, which will utilise both walk-in and walk-up and drive-through clinics as seen during the H1N1 and COVID-19 pandemics. And then with decentralised pods, these medications will be delivered directly to individuals, ensuring critical interventions reach those in need without requiring them to travel. So limited access points collection. These are designed for health and social care professionals to access antivirals for home visits to serve enclosed communities such as prisons and residential homes. So people and nurses that are home visitors would ideally use these points. Access will be managed through existing health service mechanisms, and the general public will not have access to these collection points. However, they will have access to the points of dispensing if they are centralised pods. With mass prophylaxis, this involves the large-scale administration of essential interventions such as antimicrobials and vaccines during a pandemic or during a health emergency to prevent or reduce the spread of disease. The government usually maintains a stockpile of antiviral medicines for future pandemics. The Chief Medical Officer will determine the use of these treatments, which may be limited to at-risk groups if the pandemic is mild or supplies are running low. Some responsibilities of the BLMK ICB will be to plan for the local distribution of antiviral medicines to ensure availability. They will also notify the National Coordinating Centre about collection points and any issues they've encountered. They will also monitor local stock levels of antivirals and reorder supplies as necessary, and they will follow up on the usage to ensure it aligns with expectations and arrange for the return of supplies to national stockpile. So in conclusion, these coordinated actions are vital for an effective response to a pandemic, ensuring that essential services continue and that public health is prioritised. In this section, I will explore the critical aspects of vaccination strategies during a pandemic, focusing on pre-pandemic vaccines, the development of pandemic-specific vaccines, and the delivery of these vaccines. So with pre-pandemic vaccines are developed ahead of time to provide protection against strains of influenza or similar viruses that are anticipated to cause future pandemics. The government holds a limited stock of a H5N1 vaccine specifically designed to protect healthcare workers. The effectiveness of these vaccines can vary, as it depends on how closely the pandemic strain matches the vaccine strain. Therefore, the level of protection remains uncertain until a new virus is identified. There are also pandemic-specific vaccines, also known as PSV. So the creation of a PSV vaccine begins only after a new strain is identified and isolated. So this process typically takes about 4 to 6 months. The timeline for various availability is influenced by the characteristics of the virus and how adaptable existing vaccines are to the new strain. Initially, the supply of vaccines will be limited, necessitating prioritization by the Department of Health and Social Care based on expert recommendations. Now, with vaccine delivery, they will first be offered to individuals identified as high risk by the Chief Medical Officer. This includes frontline healthcare workers and those in clinically vulnerable groups. The delivery of vaccines will primarily occur through primary care services and occupational health for NHS staff, with potential for mass vaccination campaigns. The ICBs and directors of public health will work together to set up points of dispensing, as previously mentioned, at GP practices, community pharmacies, and mass vaccination sites, which we similarly saw with the COVID-19 pandemic. Community pharmacies will play a vital role in making vaccinations more accessible. Additional arrangements may be implemented in primary care settings to ensure widespread distribution in response to demand. So in conclusion, vaccination strategies are essential for managing public health during a pandemic, ensuring that vulnerable populations are protected and that healthcare systems can respond effectively. In this section, I will be discussing the critical role of PPE, also known as personal protective equipment, and safeguarding healthcare workers and the impact of influenza on at-risk populations, particularly concerning excess deaths. So the roles of masks, masks and respirators are one of the main forms of PPE in healthcare, and the proper use of face masks and FFP3 masks is essential for protecting healthcare workers, especially when combined with other IPC measures like hand hygiene. So the difference between surgical masks and FFP3 respirators is that with surgical masks, they serve as a barrier against larger droplets, but do not provide complete respiratory protection. However, with FFP3 respirators, they are designed to protect against smaller airborne particles, particularly during aerosol generating procedures. These respirators require fit testing and training to ensure they are used effectively. So it is the responsibility of organisations to supply PPE, including conducting fit testing until the national stockpiles are required. The UKHSA provides guidance on PPE usage for healthcare settings, while employers are responsible for offering guidance in non-healthcare settings. Now, with excess deaths, influenza and influenza-like infections can lead to significant additional fatalities, particularly among at-risk groups. In Bedfordshire, potential excess deaths could reach up to 17,620, which represents about 2.5% of symptomatic clinical cases, depending on various factors. The BLRF Excess Deaths Plan outlines the strategies and arrangements for managing excess deaths during a pandemic, ensuring that appropriate measures are in place to address this critical issue. So in conclusion, understanding the importance of PPE and the potential impact of influenza on vulnerable populations is vital for effective pandemic response. In this section, I will discuss the recovery phase following the impact of an influenza-like infections pandemic. This phase is quite crucial for transitioning back to normal operations after a pandemic. So transitioning to recovery. As the effects of the pandemic begin to lessen, the UK will enter the recovery phase. It is important to start planning for the recovery as early as possible during the response phase. The pace of the recovery. This will depend on several factors, including the residual impact of the pandemic, ongoing demands and backlogs in services, staff fatigue and organisational strain, and continuing supply challenges across various sectors. A gradual return to normality is anticipated, focusing on prioritising services based on available skills and resources. Now, as we know, in the pandemic, there's huge impact to health and social care services, and they might face ongoing secondary effects leading to increased demand for care from patients whose existing health issues have worsened due to the influenza or similar infections, individuals experiencing medium to long-term health complications from their illnesses, including those whose treatments for less urgent conditions were delayed, and patients needing mental health support due to the pandemic's impact. There are several challenges in reintroducing normal operations. The return to regular operations must consider potential staff shortages, as many healthcare workers will have been under pressure significantly and may need time to recover. Facilities, essential supplies and medications may be depleted, and there could be ongoing difficulties in resupplying these resources. And additionally, critical physical assets may require maintenance or refurbishment due to backlog issues. Some broader sector impacts beyond health and social care are likely to encounter similar challenges, including loss of income and changes in competitive positioning, decreased customer bases, and shortages of raw materials. So with local recovery management, this will be managed by the Bedfordshire Local Resilience Forum in accordance with the BLRF Recovery Handbook, ensuring a structured approach to restoring services and addressing ongoing needs. So in conclusion, the recovery phase is essential for rebuilding and adapting to the new normal post-pandemic life. This slide is just detailing the appendices, which is at the bottom of the plan. So the Appendix 1 contains the National Business Continuity Arrangements. Appendix 2 contains the Pandemic Communications Procedure. Appendix 3 contains the WHO Continuum of Pandemic Activity. Appendix 4 contains the Planning and Delivery Model. Appendix 5 contains the Proportional Response to a Pandemic. Appendix 6 contains all the action cards which were previously mentioned, and then there's also the glossary at the end. And that is the end of this session. So I want to say a big thank you to everyone who's listened and everyone who has engaged and come this far. Please do let me know if there's anything that you are unsure of or anything that you need a bit more clarity on that's written in the plan, and I will be able to provide that for you. But thank you to everyone who has listened. I hope that has been informative and given a bit of an insight into how our roles are sort of involved in the pandemic response